Good morning, everybody, and welcome, particularly to those who were with us for Mitochondria Day. Very, very nice to see you all back, and even nicer to see how many new people there are who've come for Long COVID Day. So a very big welcome to all of you. I was quite interested that Mark gave a quote from Professor Danny Altman, great man at Imperial College, and working on a test actually for long COVID, because as you will see, tests are sorely lacking. So let's crack on. Oh no, I do need to explain one other thing. Mark mentioned that Dr. Shide Puria is unable to be with us due to ill health. What we've done, therefore, which won't be on your programs, is we have moved my second lecture up to Shide Puria's timing. We're then swapped my second, what would have been my second lecture with Dr. Sarah Myhill. So she's now speaking half an hour earlier. I'm then doing a few additional slides right before the practitioner panel. And then we're having the practitioner panel with expanded time. So I'm sure you'll all be pleased about that. And by the way, both practitioner panels, we would like all the practitioners on the platform, please. Doesn't matter if you're speaking this morning or the afternoon. I'm sure you can have a lot to contribute. Okay, so introduction to long COVID. What is it, first of all? Well, both NICE and NHS England define it as signs and symptoms that develop during or following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. So that seems fair enough. There are other organizations and indeed a lot of studies which look at signs and symptoms after more than 4 weeks. So that will come up from time to time as well. But anything after 4 weeks is known as post-acute COVID. And there are lots of other names for this. There's also post-COVID syndrome. There's post-acute sequelae of COVID-19 or PASC. If you've not come across the word sequelae before, it just means things following on from the Latin, same root as sequel. Chronic COVID syndrome, and in the US, long haul COVID. So you can see any of those, and it's basically anything more than 4 weeks of symptoms. So what's the government doing about it? Well, actually, it's taking it pretty seriously, which is very nice to see. It's given 18.5 million for 4 research studies. Now, actually, 18.5 million is not an awful lot for 4 research studies, but at least it's something. And they've allocated funding to set up a lot of long COVID clinics, which is great in theory. The trouble is patients can't access them. Also, some of them only look at patients who have actually been hospitalized with COVID. And as we will see quite shortly, people who've had mild COVID and indeed have been asymptomatic may also have long COVID. So that's not always desperately helpful. And they are allegedly offering upgraded exercise therapy. Sorry, Sarah, they didn't get the memo. So how's this worked out in practice? Well, here's a survey which was done, which you can read at your leisure. Incidentally, I should also explain about my slides. If you've not seen me lecture before, you'll be horrified by my slides. Yes, I can see you are. I always give you far, far more information than I can lecture, and indeed than you need or probably want. And I'm just lecturing the bits in green because they're the important ones. Please don't try and read the slides as I lecture, just follow the green bits and you can come back and look at it all later. So here's a survey of how all this has worked out in practice. And as you can see, it's not brilliant, actually, although they are trying, clearly, which is good to see. And this has given rise to a New England Journal Medicine paper, which asks, is long COVID our next national health disaster? I think you can guess the answer to that. So one of the problems in all of these issues over long COVID is the lack of uniformity in the studies. So I'm just going to quickly run through what that actually involves. So when you're doing a comparative analysis, such as in a meta-analysis of papers, you really need an agreed definition of long COVID, and there frankly isn't one. Also, there are different lengths of follow-up. Well, that makes a huge difference, because what a patient may be suffering at 4 weeks is not necessarily what they're suffering at 20. So that is another problem. Then some studies only look at patients discharged from hospital, whereas those who were at home all the time or were asymptomatic may not be included at all. Some rely on blood tests and scan results, and others focus on patient symptoms. It's very hard to generalize from a wide diversity of study methodology such as this. And then there's the testing. If you're relying on this as evidence of COVID infection, many patients, particularly early on in the pandemic, never took a COVID test because they weren't available. Also, we know fairly well, I think, that they produce false negatives and positives. And this means that patients can be wrongly allocated to cases and controls, which is critically important when you're doing a proper analysis. If they rely on antibody studies, again, some patients never produce antibodies. In others, they wane quickly. So if you're testing, say, 9 months after they've had COVID, the antibodies have gone at 6, this will count as somebody who's never had COVID, whereas in fact they have. So again, cases and controls can get really misallocated here. Researchers don't evaluate consistent symptoms or markers. Study design is very different. It can be prospective or retrospective, many other differences as well. And quite shockingly in this day and age, lack of control groups. You cannot draw conclusions on a study if you don't have a control group. So there's all those problems going on. So can we say how long long COVID lasts? No, we can't. Admittedly, it is fairly early days, but I couldn't find a single study that lasted for longer than a year. I'm sure there will be some fairly soon, but when I did my research, there wasn't anything. The Office for National Statistics, or ONS survey, is what I'm going to be talking about quite a lot, because this is a UK survey, which is extremely comprehensive. So this reported that among those who still had symptoms at 12 weeks, so that qualifies for the NHS and NICE guidelines of long COVID, 42% still had symptoms at a year. So this is not a good sign at all. It means if you're not better after 4 weeks, you've only got a close on 50% chance of recovery at a year. Patients who reported symptoms for lasting longer than 6 months, in month 7, they reported an average of 14 symptoms. Now that is absolutely horrific. And we'll see what those symptoms could be shortly, but an average of 14. So that means that some of them actually had a lot more than 14. And 86% experienced relapses. As we will see, long COVID is a relapsing and remitting condition. This again makes life very difficult in the studies, because on the day that somebody takes a survey, they can say, oh yes, I'm all better now. And the very next day they can have a relapse. Are they better? No. So you can see the problems. Here's another UK study. The authors noted minimal improvement between 5 months and a year. And we're going to be seeing that a lot. Unless you get better in the first few months, the prospects are not great. And the known existence of relapses, as I mentioned, makes it very difficult to determine the true duration. No doubt, over time, we'll get a better idea. But at the moment, it's difficult. But there is some good news, and that's that everybody's heard of long COVID now, which is fantastic, even the BBC. So let's have a look at the long COVID symptoms. So they usually present as a cluster of symptoms. They can overlap, they can change over time, and they can affect absolutely any body system. And some patients can develop new symptoms that they never had during their COVID-19 infection. As I said before, they can be continuous or they can be relapsing and remitting. And rehospitalization and death can also occur during long COVID. Admittedly, it's usually in the first month or so, but it can happen. Now, the NHS has done rather well here, I think, in recognizing all these different symptoms. So well done, NHS. Of course, they haven't picked up all of them, and there are others which I've picked up from the studies, which you can see here, together with their references. Now, this is signs and symptoms, but when you turn this into a diagnosis, it's a different kettle of fish. So here is the UK Doctors Long COVID Group, which is quite an interesting organization. So they have all diagnosed themselves with these conditions. So that's what this looks like when it's turned into doctor speak. And incidentally, if any of you doctors here are interested in joining or knowing more about the UK Doctors Long COVID Group, you've got the information right here. So I mentioned hospital readmission. So the ONS survey, incidentally, they report several times a year. So you'll see this coming up with different dates. Each one of the surveys emphasizes something slightly different to the one previously. So this is the January 2021 ONS survey of hospitalized patients only. So 29% were readmitted to hospital and 12% of them died within 5 months. That's not good. Many of them were readmitted with a new diagnosis, something they never had before, either in COVID-19 itself or as a pre-existing condition. And these are principally psychiatric conditions and diabetes and some neurodegenerative. So let's look at these in a bit more detail. New onset psychiatric conditions. So here are people, this was a very big study, and they looked at people between 14 and 90 days after infection, and they noted particularly anxiety disorders, insomnia, and very worryingly, dementia. So that's not good. Cognitive dysfunction tended to increase over the first 3 months. Oops. Diabetes. So here is a large meta-analysis, and they found that 14% of long COVID patients had new onset type 2 diabetes. There's also new onset type 1 diabetes, which is of course an autoimmune condition. And I'll be saying more about both of those later. So there are profound implications for all this long COVID. Firstly, for the state. So here's an international survey which found that 45% of long COVID sufferers had to reduce their workload and 22% were still unable to work. And this has an implications for labor force productivity, obviously, but also the cost of long-term sickness absence. It's a real problem. And then, of course, there's the implications for the individual. So this affects social lives, quality of life, daily living ability, and possible need for carers. And also, this obviously has a huge financial impact on household finances. And the latest ONS survey, which in fact was January 2022, so very recent, they found that long COVID symptoms adversely affected the day-to-day activities of 63% of those with self-reported long COVID. And here's a Belgian survey, so not just the UK, of those not admitted to hospital. So they had either mild COVID or asymptomatic COVID. 11 weeks after the infection, 44% needed new help with personal care, help they had never needed before. And 31% met the threshold for being care dependent. That's horrific. And these were not people who had severe COVID. So how do GPs diagnose long COVID? Well, with difficulty. This is what the NHS says that GPs will do for you. Remember, it is a diagnosis of exclusion, so they've got to check out a lot of other things first. But what does this mean in practice? So there are no GP tests to diagnose long COVID. So the GP is dependent upon running the usual blood tests based upon whatever the patient presents with. However, this is only of minimal use because 2/3 who underwent GP blood testing reported normal results. So that rather indicates that those blood tests are completely inadequate for diagnosing long COVID. And I'm sure our lovely practitioners talking a bit later all have their own blood tests or urine tests, which they will run. But the good thing is that GPs have been told that as long as sufferers have at least one symptom on the long COVID list, and there is no other cause found for it, the GP should diagnose them with long COVID, which essentially means that the patient is believed. If they turn up in a GP surgery and says, I think I have long COVID, I've got this, 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 and this, nothing to exclude it, the GP will write down long COVID. Fantastic. I mean, this is in stark contrast to the problems with getting chronic fatigue syndrome recognized, for example. Royal College of General Practitioners says much the same, slightly expanded list of blood tests there. And the World Health Organization agrees. Brilliant. Believe the patient. Absolutely fantastic. So let's have a look at long COVID prevalence. So I have to make the point that this is based on self-reported long COVID, not clinically diagnosed, although it may also be clinically diagnosed, but the survey is self-reported. So the latest, January 2022, and they take a smaller sample and then extrapolate to the population. So their extrapolation, as Mark mentioned in his introduction, led to the figure of 2.1% of the UK population suffering long COVID. This is not more than 12 weeks, this is more than 4 weeks, but still, that's a very high proportion of the UK population. So here we've got 71% who had or thought they had COVID at least 12 weeks previously, and 42% after a year. So you can see the point I was making. If you don't get better in the first few months, the indications are not good afterwards. 42%, and again, that's not far off 50. Here's the September 2021 survey, which came up with a different extrapolation for the UK population. So all this says is that the prevalence fluctuates according to who's being asked, which is common sense, really. But you cannot rely on one set of numbers and just say, well, that's it, because it's going to vary. And it varies between international surveys and other national surveys. There is no one number. Fatigue, however, I'm back on the ONS survey now. Fatigue is the most common symptom reported, followed by shortness of breath, and then loss of smell and taste. Amongst the UK population, females are more likely to get long COVID, and people between the age of 35 to 69. So of course, this is in complete distinction to severe COVID-19, where it's males and the elderly. So that's quite interesting. But this particular September 2021 survey did raise questions about whether long COVID actually exists, a point I will be returning to later. So 5% reported one or more of 12 common symptoms at 12 weeks, but 3.4% of the control group, so in other words, the population that didn't have COVID, reported similar symptoms. So this suggests, they say, that coronavirus may not be to blame in the majority of cases. Well, possibly not. As I said, I'll be coming back to this. Other UK studies, we've had the Zoe app study, which you're probably familiar with. Okay, thank you. Run by Professor Tim Spector at King's College. Risk factors. So age and gender. So females, definitely, but there is no clear consensus on age. And I'm taking all studies now, not just UK studies. Ethnicity, there is no clear consensus. Correspondence with COVID-19 risk factors, no clear consensus. Pre-existing mental health, okay. Those who have a pre-existing diagnosis of depression, anxiety, or any psychiatric disorder have a higher prevalence of long COVID. Severity of initial COVID symptoms, no clear consensus. Test results on hospital admission or discharge, no clear consensus. Relationship with current tests or scan results. So even among patients asymptomatic for COVID-19, MRI scans still reveal cardiac problems in 78% of them and ongoing myocardial inflammation in 60%. These are asymptomatic patients. That's pretty amazing. And these were independent of pre-existing conditions and severity and overall course of COVID-19 and time from the original diagnosis. The impact of vaccination. You should be aware that the UK Health Security Agency has done a review, picked out 8 studies, looked at the effect of vaccinations administered before infection, and found that most of them, not all, but most, found that 1 or 2 doses of the vaccine rendered the patients less likely to develop symptoms of long COVID. I've not looked into these studies. I've not critiqued them. I'm not a vaccine expert, but you need to know they exist though. Medications as risk factors for long COVID, yes. Steroids, definitely. Something we'll be seeing again later. Children, here's a comprehensive review, 14 studies. Although the risk of severe COVID is low, there may be a greater risk for long COVID. Symptoms rarely persisted though beyond 12 weeks. So that's good news for children and adolescents at least. But a lot of the studies were poor quality. Really no excuse for this. But also the authors have commented that long COVID symptoms are difficult to distinguish from pandemic associated symptoms resulting from school closures, not seeing friends, can't do sports and hobbies, all of that. Coming back to that later. And here's the clock study. This is an international study of adolescents led by the UK, but it's international. So this showed that those with a baseline positive PCR test had a similar symptom profile to those with a negative PCR test. So this again caused a lot of comment in the Twitter sphere. One of the researchers said, makes it nearly impossible to attribute any symptom or group of symptoms specifically to the effects of COVID-19. But they are overlooking the problems, some of which I've alluded to already, of using a PCR test to determine whether somebody has had COVID. And finally, I think we have to ask, but I'm not sure we'll ever know the answer. Thank you.